Hello and welcome to the AAPA Free CE webinar. Today's webinar, titled Laryngectomies and Neck Dissections, will be presented by Sarah Garner. Sarah is the Director of the Pathologist Assistant Program at Tulane University School of Medicine and an active member of the AAPA. She serves on the Marketing and Communications Committee as the Electronic Communications Subcommittee Chair and is a member of the Advocacy and Media Subcommittees. She is also a member of the Education Committee. Sarah enjoys sharing educational information about pathology and anatomy via Instagram. You can receive one CE for today's webinar. In order to receive your CE, watch the full webinar and complete the quiz at the end. You must pass the quiz for the unit to appear in your personal online CE journal. If you have provided your 8-digit ASCP customer ID, and as a new requirement, your first and last names must be an exact match to your ASCP profile, the AAPA PACE credits you earn will seamlessly transfer over to your ASCP transcript on a weekly basis. The learning objectives for today's webinar are: describe the pertinent neck anatomy related to neck dissections performed for laryngeal carcinoma, discuss the relevance of anatomic structures of the larynx and neck with respect to staging of laryngeal carcinoma, acknowledge the characteristics of supraglottic, glottic, subglottic, and transglottic tumors, and briefly describe the components of neck dissections and the related pertinent anatomy. And now, without any further ado, I will turn the presentation over to Sarah.
All right, y'all, welcome back to the webinar series. My name is Sarah Garner. Today we're going to cover laryngectomies and a little bit of neck dissection as well. So in the first webinar, we covered colorectal surgical margins. So if you missed that one, you can catch that on the AAPA's website or on YouTube. And this one, like I said, we're going to talk about larynx and neck dissection. So this is designed specifically for pathologist assistants, but this can apply to anyone who is grossing these specimens. So pathology residents may find this very helpful as well. So what we're going to do is we're going to go over the anatomy and have a brief review of the pertinent anatomy. We're going to go over staging of laryngeal carcinoma, and then we're also going to briefly touch on neck dissections. So our main goal is to understand the anatomic landmarks and spaces of the larynx and how that affects staging. So something that I find is commonly misunderstood or just kind of overlooked sometimes when grossing larynx specimens are those spaces. And so that's one of the main goals of today. So a brief neck anatomy review. We're just going to cover the pertinent structures for neck dissections and larynx specimens. I could talk all day about neck anatomy, but I will spare you. If you want additional neck anatomy review, I'm happy to provide it. I do teach a separate class on that. So we're going to go over a couple of the layers of fascia and some of the muscles and just some of the neurovascular structures. And the reason we go over this is because it's not enough to know the anatomy of just the specimen in order to fully understand staging, right? So oftentimes, because we're receiving these specimens after they're removed from the patient's body, it can be easy to forget the surrounding anatomy. And that is what a lot of the staging is going to be based on. So to start with the fascia, if you remember from gross anatomy, there are a couple different layers of fascia in the neck. So you have the superficial cervical fascia, and then you have the deep cervical fascia. There's 3 layers of that, and those 3 layers of the deep cervical fascia kind of all contribute to something called the carotid sheath, which you probably remember surrounds a couple of different neurovascular structures in the neck. So the deep cervical fascia, you have 3 layers. You have an investing layer, which is kind of the outermost part. We're not really concerned about that today. And then you have the pretracheal and prevertebral fascia. So here, this is a drawing that I've labeled for you so you can see what I'm talking about. But on here, this would be what I've drawn in the red. This is the pretracheal fascia. So here in the red, pretracheal fascia. Now the pretracheal fascia can be split into two parts. You have a muscular part over here anteriorly, and that's going to surround the infrahyoid muscles, or those strap muscles. And then you have a visceral part kind of more posterior here, and this is going to surround the thyroid, the trachea, and the esophagus. So importantly, the posterior part of this pretracheal fascia is formed partially by the buccopharyngeal, the buccopharyngeal fascia. So this red part back here that I just outlined in yellow, a lot of that is coming from the buccopharyngeal fascia, which, if you don't remember, is one of the fascial coverings of the pharynx. And this is going to be important in a second. Then you also have this green that I've drawn on here. This is called the prevertebral fascia. So it does go back here as well, but I've kind of cropped that out for this picture because that's not really what we're concerned with for today. So here what I've drawn in the green is that prevertebral fascia, and it's just what the name tells you, prevertebral, so before or anterior to the vertebrae. And so on here, notice that the prevertebral fascia and that portion of the buccopharyngeal fascia that forms the pretracheal fascia here, they kind of rub up against each other back here, but importantly, there's a potential space in between those. So this potential space is called the retropharyngeal space, and this is a really, really important space. So a lot of times potential spaces kind of get overlooked, but potential spaces do have a lot of potential. So this one in particular, if you get an infection or cancerous cells that go into this retropharyngeal space, they can actually spread into the mediastinum, because if you remember, the retropharyngeal space begins up at the base of the skull, and it's continuous all the way down into the posterior mediastinum. So if we have a laryngeal carcinoma extending into the prevertebral fascia, that's going to be higher stage, which we'll see later, because it can then extend into that posterior mediastinum. So here, this is a cadaveric dissection from my anatomy class, and you can see I've labeled it the same way so that you can kind of flip back and forth between the two. And this one, what I did was I dissected it, and then I can kind of like pull this part anteriorly so that you can actually see that space. So normally, if this was just sitting still, you wouldn't see that space, but what I did was I pulled it so that you can actually see what that potential space can look like if it becomes a true space. So here, this would be that red, so that would be that buccopharyngeal fascia. This green here would be that prevertebral fascia. And so then this here is that space, the retropharyngeal space. Now, this is a separate dissection, but same view. And so here, again, you can just see this, I pulled a little bit less. So I just wanted you to see that fascia. So your larynx is going to be all the way here anteriorly. So for a laryngeal carcinoma to extend all the way in there, that's going to be pretty aggressive, right? And so the main thing I want you to take away from this is that if something invades into the prevertebral fascia, it has access to that retropharyngeal space and can then spread. So then here, this is just labeled for you so that you can have this in your handout showing you that space that I just showed you as well. So now moving on to the muscles, there are tons of muscles in the neck, but for our purposes, we're only going to review some of them. So we're going to talk about the trapezius and the sternocleidomastoid, and then we'll touch on a few of the supra and infrahyoid muscles. So starting with the big ones, your SCM, or your sternocleidomastoid, and your trap here. So these are important for forming the triangles of the neck. So if you don't remember from anatomy, recall that you have an anterior triangle of the neck here and a posterior triangle of the neck here. Now the anterior triangle of the neck is then subdivided into 4, and the posterior triangle is then subdivided into 2 triangles. And this is going to be very similar, not the same, but similar to what we're going to see when we go over the different levels of the neck. So the sternocleidomastoid is a great reference structure when you're trying to orient things in the neck, and a lot of those levels that we're going to talk about are based on where they are in relation to that sternocleidomastoid. Now, if you remember from anatomy, the sternocleidomastoid and the trapezius are both innervated by the spinal accessory nerve, which is your cranial nerve number 11. It's an entirely motor cranial nerve, and it comes out here, right about here at the jugular foramen, will innervate the sternocleidomastoid here, and then it'll travel across this posterior triangle to then innervate the trapezius as well. And that's going to be an important structure for us to see later on. So if we flip it and we're looking at an anterior view, the suprahyoid muscles and the infrahyoid muscles are named by where they are in relation to the hyoid. So here's your hyoid bone, and there are 4 muscles superior to that are grouped as the suprahyoid muscles. So these are the geniohyoid, the digastric, the mylohyoid, and the stylohyoid. But for our purposes, what we're really concerned about are the digastric muscle and the stylohyoid muscle here. And then the infrahyoid muscles are going to be inferior to the hyoid, and again, there's 4 of them, but the only ones that we're going to be concerned about for our purposes today are the omohyoid and the sternohyoid here. So in general, the suprahyoid muscles, they're above the hyoid, and so they're going to function in pulling that hyoid up or elevating it, whereas the infrahyoid muscles in general, this is kind of simplifying it, but in general, they're going to depress that hyoid. So these are named by where they are, and so here the omohyoid muscle, remember that omo refers to shoulder, so the omohyoid actually has 2 bellies. This would be the superior belly here, and then the inferior belly is going to actually dive out towards the scapula, hence the name omohyoid. The other one that has 2 bellies is the digastric, which it kind of tells you in the name, digastric, so it's going to have an anterior belly here, and then it's going to have a posterior belly here that dives back towards the ear. Now the stylohyoid is going to kind of wrap around that right here. So it starts at the styloid process, which is right next to that mastoid process right behind the ear, and it's going to insert on that hyoid bone right here. And then our last one that we're concerned with again is that sternohyoid muscle here. So it's telling you exactly what it is. It goes from the sternum down here up to the hyoid bone. So just keep these in mind for later on once we get into the neck dissections. Now, the neurovascular structures that we're concerned with, we have the common carotid artery, the internal jugular vein, and that spinal accessory nerve. So what I did was I did this dissection and kind of put it next to these cartoon pictures so that you could compare them. And I went ahead and labeled them so that hopefully it's less overwhelming. But here you can see those muscles we just talked about. So this would be that sternocleidomastoid muscle. You can see its 2 heads attaching here to the clavicle and the sternum. You can see the hyoid bone here, so then you can see the supra and the infrahyoid muscles down here. Now, importantly, you can see the sternohyoid muscle here, as well as the superior belly of the omohyoid right here. Those are going to be important later on for orientation. And then notice you can see those neurovascular structures I just mentioned. So here, this would be your common carotid artery that I labeled with CC, and then here, this would be that internal jugular vein. So this is kind of a little bit more to the side, so you can see the rest of those suprahyoid muscles, but the only ones that we're really concerned with right now are the anterior and posterior bellies of the digastric here and here, and then the stylohyoid, which you can kind of see wrapping around the posterior belly of digastric right there. You can also see the beginning of that inferior belly of the omohyoid right here. All right, so if we reflect that sternocleidomastoid, this is when you're going to start to see the lymph nodes by the jugular vein, the internal jugular vein. So remember, you're going to have a bunch of lymph nodes in and around right here in that area, and those are going to be important for levels 2 through 4 of a neck dissection. But also note that you can see the spinal accessory nerve innervating the sternocleidomastoid right here. So those are the muscles that are surrounding the area, and those are going to be our reference structures. But we also need to think about the larynx, where it sits in relation to all of these structures. So remember, the larynx is going to be posterior to the strap muscles. That is super important for when you get a laryngeal specimen and you're trying to orient it. So you're going to have the strap muscles, or those infrahyoid muscles, these guys, anterior to the larynx here. Now, notice that you also have the hyoid bone right here, so just notice the relationship between the hyoid and the larynx here, and then also notice that this bump right here, that would be that laryngeal prominence or that Adam's apple, so that should hopefully help you visualize it on a patient. Okay, so now we're going to go over the anatomy of the actual larynx itself, and this, I didn't want to just give you a video of me going over a model or on a body, because I know it can get really overwhelming and it's hard to orient. So what I did was I put pictures on here, kind of like I did with the neck anatomy, and you can actually take these cartoon pictures and compare it to whatever I'm going through, whether it's the model or on the body or a specimen. So I put all three views on here for you. So here, this would be your anterior view. It's a little bit anterolateral, but it's showing you the anterior view, so you can see the cricoid, the thyroid cartilage, as well as the hyoid bone up here. You have the posterior view here, and then you have the lateral view over here. So anterior, posterior, and then lateral view. And this is bisected, so you can actually see the inside. So this is an internal view, right? So now I'm going to do a split screen, and you can kind of follow along using these cartoon pictures as I go through this. Okay, so this is a 3D printed model that we just recently made and printed because larynx anatomy can be tough. And so we thought that making it big like this would really help. And so here you can compare this to that picture. You can see that this up at the top, this would be that hyoid bone. And then here, this would be that thyroid cartilage. So this would be that bump right here. See, that's that laryngeal prominence. Then remember, the thyroid cartilage doesn't go all the way around, so you can see the posterior edge of it here. So this up here would be hyoid. This would be thyroid cartilage, right? And then you can see this cartilage that does go all the way around. So this is that cricoid cartilage, and you can see anteriorly it's not that wide, but then if we flip it over, look how wide it is posteriorly. So this would be cricoid cartilage. And so when you're opening up a larynx specimen, you would open up through the trachea, which is this part here. And remember, at the back of the trachea, it doesn't go all the way around. It's connected by that trachealis muscle, so this is easy to cut. Then you get to the cricoid cartilage. It can be kind of tough to cut, and that's because it's the only one that goes all the way around. So thyroid cartilage, cricoid cartilage. Then you have these two little cartilages right here. These are your arytenoid cartilages here. And then the last one is this, which is your epiglottis. So if we look at it from a superior view, look how beautiful that is. You can see this would be hyoid, this would be epiglottis, this would be the cords right here. So I don't know if you can appreciate that from this view, but that's your true cord right there. And then these would be those arytenoid cartilages, and then in that hole right there, that would be the trachea. So again, we have epiglottis, arytenoid cartilages, cricoid cartilage, thyroid cartilage, and hyoid bone. Okay, so this is a bisected head anatomy dissection so that we can review the different structures on the larynx and the surrounding area so we can better understand those areas that are really important for staging. Oftentimes it's really hard to visualize these areas, especially on a specimen that is cancerous, because oftentimes the tumor has actually already invaded into that area. So this is a common thing that a lot of people struggle with, is visualizing these spaces and also understanding why they're important. So up here, let's start proximally. So we have, this would be soft palate and the uvula hanging down here, right? So up here, this is the nasopharynx. You can see the opening to the eustachian tube in here. So this area is nasopharynx, and then here would be oropharynx, right? So this is going to be the back or the base of the tongue. This is the oropharynx. And then we're going to go down into here. So this is going to be your laryngopharynx or your hypopharynx. Now I've opened that up already so that you can actually see where we're at. So here, if we open that up, this is the larynx in front of it. So I've already opened that up, but pretend that this is closed here. So we have the epiglottis, and then this would be the anterior boundary of the pharynx, right? If we had closed this. So this would be, my thumbs are inside the pharynx, specifically the laryngopharynx or the hypopharynx, so the part that is directly posterior to the larynx. So all of that is here, and then it's going to turn into the esophagus down here. So this is the esophagus opened up, and then this would be the trachea opened up. So if we flip this anteriorly so that we can review the larynx structures, remember the base of the tongue is going to be right above that epiglottis here. So this would be base of tongue, this is the epiglottis. Now looking at it from an anterior view, so this is still a medial view obviously, but then I've rotated this so that this is if you're looking at the patient face on, this is an anterior view here. So if this is an anterior view here, the first thing you should notice is this big bump right here. That is your laryngeal prominence or your Adam's apple, and that is that bump on the thyroid cartilage. So this is a really good reference structure. So here you can see that all of this is thyroid cartilage. Here's your thyroid gland. Now we have already removed the majority of the strap muscles here, and normally your strap muscles would sit anterior to the thyroid here. So all of this is thyroid gland. Notice that the thyroid gland sits a little bit inferior to the thyroid cartilage. So here's the thyroid cartilage, thyroid gland. Now if we flip it posteriorly, that's where we're going to start to see a lot of the important structures. So here, this is a posterior view of the pharynx. So remember, the posterior boundary of the pharynx is made up of the superior, middle, and inferior pharyngeal constrictor muscles, and that's what this is. So this is just a cross-section through the pharyngeal constrictor muscles to open up that back wall of the pharynx. So we've cut through those, we've opened this up. Now we're looking at the back of the larynx, right? So if we flip it up this way to look at the inside a little bit, here, remember that the epiglottis is going to fold posteriorly, so this is the entrance or the laryngeal inlet. Now, remember that back here you have those arytenoid cartilages. So here under this mucosa, like you're not seeing that cartilage right now, but you can feel it under here. This would be arytenoid cartilage. So then this mucosal fold that goes from the arytenoids to the epiglottis is called the aryepiglottic fold. So you have a left aryepiglottic fold here and a right aryepiglottic fold here. Those are going to be important for orientation and for sectioning. So here, this would be the posterior mucosa, these would be the lateral mucosa, and then here, this is the anterior mucosa or the vallecula. So if you're just receiving a laryngectomy specimen, this would be cut and this would be a surgical margin. But here in the body, it's still attached and continuous with the mucosa that's going to go up and cover the tongue. So here would be the back of the tongue, and then this right here is that anterior mucosa or that vallecula. So before we open this up and look at the rest of the structures, let's get these spaces down. So on the side over here, I can feel, I know you probably can't see it, but see this bump right here? That is the thyroid cartilage. So I'm going to keep my finger on this and then I'm going to flip it over. Where that is right here. So this is literally just the edge of the thyroid cartilage here, and you're going to see the same thing on this side, because remember, the thyroid cartilage doesn't go all the way around like the cricoid cartilage does. So the other bump is right here. So here and here, these are the borders of the thyroid cartilage. So if I pull on this, you can kind of see the outline of the thyroid cartilage from the back. So the piriform sinus is going to be in between the aryepiglottic fold and the thyroid cartilage. So in between here, that is that piriform sinus. Same thing over here. So in between the aryepiglottic fold here and the thyroid cartilage here, that is the piriform sinus. But the pre-epiglottic space and the paraglottic spaces are difficult to see unless you cut into the specimen. So we'll do that in a little bit. But for now, let's go over the inside of the larynx, just normal anatomy. So if we open it up, so remember that the cartilage is the only cartilage is that's gonna go all the way around is that cricoid cartilage. So when you're opening a larynx from the back to let it fix, you're actually cutting through that cricoid cartilage. So here, that's exactly what we've done. So we cut through cricoid cartilage here and here, and then we've opened it up to see, wow, this is so beautiful. Epiglottis, aryepiglottic fold, the arytenoid cartilage is in here, covered by all that mucosa. So I can feel it, but you can't really see it. And then see this muscle here on both sides? That's going to be your vocalis muscle. Remember, that's what's actually tensing and moving that true vocal cord, and that's going to help with speaking. So here, this is going to be, see this space? This is the ventricle. So on either side, you have this ventricle, and then the top cord or fold, this is going to be your vestibular fold or your false vocal cord. So that's here and here. And then the bottom one, the inferior one, this is going to be your true vocal cord, or also called your vocal fold. So here. And if you ever forget which one's which, just remember that the vocalis muscle is at the level of the true vocal cord because it's moving that. So the true has to be on bottom. So it's going to be the false cord, the true cord. Now where these come together anteriorly, that's going to be the anterior commissure. And where they come together posteriorly, that would have been the posterior commissure. So we kind of cut through that to open this. So you got to be careful when you're taking those sections. So here, this would be anterior commissure. And then remember that space is called the ventricle. So when you're talking about the three different levels of the larynx, it's important to know these anatomic landmarks in order to know what's supraglottic versus glottic versus infraglottic. Now let's go over the laryngeal structures that are present in addition to the different cartilage. And here, this is a dissection, and I'm going to go through the dissection, and I also took a picture and labeled some of the pertinent structures, so again, you can follow along using the picture. Okay, so this is the tongue taken out with the entire pharynx and larynx, and then the trachea here. If you flip it over, you can actually still see the posterior belly of digastric. So remember that the posterior belly of digastric is more tendony here, and it goes right in between the belly of the stylohyoid. So this is stylohyoid kind of splitting, wrapping around the tendon of the posterior belly of digastric. So anterior digastric, posterior digastric. You can also still see your hyoglossus, your submandibular gland, your facial artery here. So if we flip it back over, here's your tongue at the very base of the tongue here. You see this is your vallecula. This is the epiglottis, which is going to fold down. So this is your uvula here. See, they kind of almost touch here. So from a posterior view, what it looks like is this. So this is the back of the pharynx opened up. You can see the uvula hanging down. You can see the epiglottis here. So this space, like where my thumbs are, that's your pharynx. This would be closed, and now where the probe is, that's your larynx. So pharynx is posterior to the larynx. Here you can see it's still covered in its mucosa here, but if you look right there where we cut, those are your pharyngeal constrictor muscles, which make up the posterior wall of the pharynx. So to open up the larynx, we cut through the only cartilage that goes all the way around, which is your cricoid cartilage. So this right there and there, that's your cricoid cartilage. We cut through that. You can also see your vocal cords. So this here, that's your true cord, right there and right there. This here, that's your false cord, also called your vestibular fold. So true, false, that little space right in between them, that's your ventricle. And then where they meet at the front here, that's your anterior commissure. This area above those, where the opening is, that's your vestibule. So I like to think of this as the vestibular fold versus the vocal fold, because it's more superior. That helps you remember which one is superior, which is inferior. You also have the aryepiglottic fold here. So that is this very loose part that allows the epiglottis to fold posteriorly to cover up the airway so you don't inhale food. So this would be your epiglottis, aryepiglottic fold, and it's called the aryepiglottic fold because it attaches to the arytenoid cartilages, which are right there. And then in the infraglottic space here, once that ends, now you're into the trachea, which is going to go down. We opened it through the trachealis muscle here, and then it's going to split into primary bronchus. Your other primary bronchus would be right here, and then those are going to go to your secondary bronchi. So for my histo people, if you think of the epithelial lining of this, remember that your true fold is going to move mainly by the action of this muscle right there, which is your vocalis muscle. And so since it is moving, it's more subject to abrasion, and so that's going to be lined by your stratified squamous epithelium versus your false cord. It's false because it's not really moving as much or really at all, and so that's going to be lined with your respiratory epithelium, which is your normal pseudostratified columnar with cilia. And then last thing, you've got the vallecula again here. This is from the posterior view. So this is uvula, tongue, vallecula, right at the front of the epiglottis where it folds down. So once you know all the different components of the larynx, then you can split it up into its 3 areas, and this is going to be really important for grossing because you definitely want to note the location of that tumor. Is it a supraglottic tumor, a glottic tumor, a subglottic tumor, or is it a transglottic tumor? And so it's important to know your anatomy so that you can divide it into these 3 different areas. So the supraglottis is going to go from the top of the epiglottis to the level of the ventricles. And so it's going to include the epiglottis, the aryepiglottic fold, the arytenoids, the false cords, and part of that ventricle there. The glottic area is small, so it's going to extend only from the ventricle to about 1/2 to 1 centimeter below the level of that true cord. And so this, importantly, is going to include that anterior and posterior commissure. And remember, those are just where the cords are meeting either anteriorly or posteriorly. And then inferior to that, so from about 1 centimeter below that true cord to the inferior margin of that cricoid cartilage, that's going to be subglottic, okay? So these are going to be important. You always want to note in your gross description where exactly that tumor is. So margins of a laryngectomy, the inferior margin is typically going to be a tracheal ring, but of course it depends on the specific specimen. Some are going to have a couple tracheal rings, some may not have any. So this, just keep in mind, it may not always be that. It may be a different type of inferior margin, but typically in most cases it's probably going to be that inferior tracheal ring. So this, depending on where your tumor is, you can either shave or take a radial or a perpendicular of this. So if your tumor's close, obviously you would want to take a radial or a perpendicular so you can show that relationship and you can actually measure that distance. your mucosal margins, you're going to have basically a ring of mucosal margins that go around kind of like the top or opening of that larynx. And I'll show you this on a picture on the next slide. You're also going to have soft tissue margins, and this is super variable depending on whatever the specimen is going to be. So this, you're just going to have to use your judgment and your anatomy skills, which is why we reviewed the anatomy. So with all of these margins, even if the tumor looks grossly far-ish away, typically a radial is going to be better than a shave, because for laryngeal carcinoma specifically, you always want to be able to measure that distance to the tumor or the distance to dysplasia, because it's not really agreed upon what exactly a positive margin is defined as. And so if the pathologist can put in the report exactly how far dysplasia and or tumor are, it's very helpful. So at most institutions, a radial is typically going to be better than a shave. So this is more or less what an actual laryngectomy specimen would look like, less anatomy, more just what you would get as a larynx specimen. So here at the top, you can see the epiglottis, you can see those area epiglottic folds, you can see the arytenoid cartilages, and then this would be an example of what a mucosal margin would look like. Now, obviously this is very fixed, so it would be more reddish in a fresh specimen. But here, I really just wanted to point out the mucosal margin. So here, you can see that this is a great example of what an anterior mucosal margin might look like surgically. So here you can see that this has been cut. You can see the edge of the mucosa. So all of this would be that anterior mucosal margin, or that vallecular margin. So you have the anterior mucosal margin, you'd have another mucosal margin over here. Now, obviously, sometimes it'll be cut higher up, like over here. It just kind of depends on the specimen. But if you see the edge of the mucosa where it's clearly cut, this would be that margin here. So this is an example of a specimen, so I can show you the margins on here. So for orientation, this would be a posterior view. This is an anterior view, and then this one over here is like anterior superior view. So here, this would be the posterior part of that thyroid cartilage. This would be epiglottis. So the main thing I want to show you on these is the mucosal margins. So here you can see that this is nice, pink, shiny, and then this is more just like soft tissue, right? So you can clearly see the difference right there. So all of this would be mucosal margin. And then if we flip it and look at it anteriorly, here you're seeing that anterior mucosal margin, and then if we flip it even more superiorly to look at it a little bit closer, you can clearly see the edge here. So this would be that anterior mucosal margin. So it kind of depends, it varies by institution. Sometimes you'll just shave the entire thing or take a radial of it and just call it anterior, but I know a lot of institutions also prefer you to actually split it into right and left, because remember, it's important to note whether the tumor has crossed the midline. So sometimes you'll have to shave or perpendicular right versus left. So just keep that in mind. And then your lateral, it's kind of hard to see in the picture, but think of this as a ring going around. So if we had that anterior margin kind of anterior to the epiglottis in there, it's going to kind of come around like a ring like this. So the lateral margins are really dependent on the specimen. Sometimes it'll just be that area epiglottic fold. Sometimes you'll have a little bit of mucosa kind of flapping off the side of that. But in general, your mucosal margin should be a ring all the way around the top of the specimen there. And then let's erase this. Your inferior margin, so in this case, the tracheal margin would be down here. And then all of your soft tissue margins, again, this is going to vary by specimen, like what's present. Is there a thyroid gland? Is there strap muscles? Is there a neck dissection attached? So you're just going to have to use your anatomy knowledge there, but all of this would be soft tissue, right? And same thing here, this is all soft tissue. And then notice you also have this opening here. So depending on the tumor location and size, these are fairly common in people with laryngeal cancer. This is a tracheostomy site, and so you definitely want to get a section of that. Some people prefer you to take a full margin all the way around that, but I know that's institution dependent, so just keep that in mind. And if you have a tracheostomy site, you always want to mention it and section it. Here's another example. This one has a lot more soft tissue on it, right? And so here, this is an anterior view, and you can see all of this soft tissue attached here. You can also faintly see the opening for a tracheostomy. And then on the posterior view over here, you can see the cricoretinoid muscles really beautifully here, but I mean, that's just soft tissue margin here. You can see hyoid, you can see epiglottis here. So on here, you can see another example of a mucosal margin. So right here, this would be the right posterior and the left posterior mucosal margin. The lateral margins would be right about here, and then we'd have to kind of flip it to see that anterior or vallecular margin. So remember that those are kind of interchangeable terms depending on the institution and the person. So vallecula typically is going to be synonymous with anterior mucosal margin. So that's the basics of the laryngeal anatomy itself, but the thing that throws people off are those spaces. So spaces of the larynx, you have the preepiglottic space and the paraglottic space, and those are continuous. And then you also have that piriform sinus space. So the preepiglottic space here, I have highlighted on the left. So on here, you can see that this would be that anterior mucosa. So right here, this would be that vallecula. And then this would be the anterior edge of that epiglottis. Here would be the hyoid, and then here would be the thyroid cartilage. So the preepiglottic space is in between the epiglottis and the hyoid bone superiorly, and then in between the epiglottis and the thyroid cartilage inferiorly, as well as kind of in between this anterior mucosal fold. So it's essentially just this area filled with fat and some connective tissue. So anatomically, it's not that significant. But if you have tumor extending into that space, that is upstaging the patient that's going to have a poor prognosis than something that is not going through there. So it's important to understand where that is because you need to take a section of it in order for the proper staging to be determined, right? Now, the preepiglottic space, if you're kind of rotating around the larynx, is continuous with the paraglottic space. So the paraglottic space, if you think of where the glottis is, and para means like on the side of, right? So pre means anterior to or before, so we just saw that. Para is going to be on the sides. So it's going to be on the side of the glottis. So remember, the glottis is basically this area here, but notice that the paraglottic space is a lot bigger. So here, it's going to be just lateral to the two cords and medial to that thyroid cartilage. So here, this would be that thyroid cartilage. And so it's basically between the actual, like, I think of it as like the mucosal edge of the inside of the larynx, and between that and the thyroid cartilage. And this, again, it's continuous with that preepiglottic space. So I made a video showing you this on an actual specimen. Okay, so this is another larynx removed, and here to orient, we have the hyoid bone here. This is the posterior part of the thyroid cartilage, so you can see that those are connected here. So this would be hyoid bone, thyroid cartilage. Then back here we've got the cricoid cartilage, and up here we've got the epiglottis, okay? So this is a posterior view. Now the first thing you want to notice is that piriform sinus. So again, the piriform sinus is going to be that area in between the area epiglottic fold here and the thyroid cartilage here. So my probe is now in the piriform sinus. So the piriform sinus is its own separate space, but then you have two other spaces, the pre-epiglottic space and the paraglottic space, that are actually continuous with each other. So in order to see these, you have to cut the specimen, because otherwise all of this is connected and it's a space kind of in there that you can't really see or visualize. So if we cut that sort of in half and we open it up like this, we can see that we've cut through the epiglottis here. So this is epiglottis and epiglottis. You can see the cords. You can see the cricoid cartilage here. You can see the vocalis muscle here. So what we're concerned with right now is the spaces. So we have the epiglottis. So just in front of the epiglottis, you have this area that is filled with connective tissue and fat, and this is that pre-epiglottic space. So pre is before, so it's going to be right in front of or anterior to the epiglottis. So here's the epiglottis folding posteriorly, here's that vallecula, right? So then this is that pre-epiglottic space. Now that is going to be continuous with the paraglottic space, which is more so on the side. So it's going to be over here, but you can't really see it, right, unless you cut into that. So on this side, now let's look at it. And so here, if this is the epiglottis, where we've cut it here, this would be that pre-epiglottic space. Now if we look and we follow that, so I'm going to put this down, if we follow that, here's that pre-epiglottic space. Now we made another cut here, so let's open it this way. And if we look, this is epiglottis. So this, if we flip it this way, this is still epiglottis here. So this is that pre-epiglottic space. And now look, it's continuous with this space that's filled with fat and connective tissue. So this is now the paraglottic space. This is no longer the pre-epiglottic space because the epiglottis is ending. There's only a sliver of it left here. So here is the edge of the epiglottis. So after that, like here it would be pre-epiglottic space, but now we're getting into that paraglottic space, but it is one continuous space, okay? So you won't see like fascia or anything separating the two. It's just a continuous space. It's just named different things by where it is. So pre would be in front of the epiglottis, and then paraglottis is on either side of the glottis. So here, this whole fat-filled area here, this would be that paraglottic space. So this cut is that thyroid cartilage. So if we put it back together to kind of figure out where this is anterior, this is posterior, this is that sliver of epiglottis that's left. So this would be that pre-epiglottic space, and where that cut is right here. So it's on the lateral side, and if we open it up, there's that thyroid cartilage, and here's that paraglottic space. So when you're taking a section of that, you want to go through, basically like I did here, and cut here and see if that tumor is extending into that fat-filled space there. Okay, this is a perfect specimen to go over the piriform sinus. Here, this is a posterior view. So this is the posterior part of the pharynx. So this is going to be those pharyngeal constrictor muscles here. See that we cut through those to get into the pharynx. So this is pharynx, and then this is larynx, right? So we've already cut through the posterior part of the larynx here. Now, if we open it up, this is a perfect example of those arytenoid cartilages. So here, this would be arytenoid cartilage, and then this would be the epiglottis. So remember, connecting the arytenoid cartilages and the epiglottis is going to be that airy epiglottic fold. So that's going to be here and here. So you have airy epiglottic fold, and now this over here is the edge of that thyroid cartilage. So this is why this is a perfect example. So here, this is the thyroid cartilage coming around, this is the posterior portion of it, and then that piriform sinus, remember, is going to be the space in between the airy epiglottic folds medially and the thyroid cartilage over here. So here's the border, this is the piriform sinus here, okay? So piriform sinus, remember that's going to be separate and different than the pre-epiglottic space and the paraglottic spaces. Now I want to go through a case example to show you why these spaces are important, because I feel like a lot of times these spaces are still overlooked, but they are very significant for staging. And so sometimes if you're not really understanding exactly where that space is, you may take a section and call it that space, and it may not actually really be that case. And so that patient may be either overstaged or understaged, which can really affect their treatment and their quality of life. So this is a specimen. These are the anterior and posterior views of this specimen. So over here, this is the anterior view, this is the posterior view, and you can see that this would be that inferior mucosal margin. You can see the hyoid, you can see the epiglottis. Overall, this is a really nice laryngectomy specimen. And then on the anterior side, you can see that there's a lot of soft tissue. There's an opening for the tracheostomy. So this overall is a really nice specimen. Now, opened it up, and here you can see it really doesn't look too bad, right? But as you're probably aware, with a lot of these head and neck cancers, they can be very endophytic. And so sometimes when you first look at it, it doesn't seem like it's going to be that bad. But then once you cut into it, it is everywhere. And that's exactly what happened in this case. So here, when you're first opening it, you might be thinking, oh, okay, this tumor's not that big. It looks kind of just confined to this area here, maybe this down here too. Here you can see the inside of that tracheostomy site, but notice if you look closely, that actually looks kind of abnormal as well, right? And so I will tell you that that actually ended up having squamous cell carcinoma in it as well. And here's why. So once we bisect it, now you can see that that tumor is actually, in fact, huge. And this is the case, like I said, with a lot of head and neck cancers. It can be very kind of, I guess, misleading at first glance because they can be very endophytic. So here you can see this is that same exact specimen, it's just fixed, and you can see that tumor actually invaded very deep going anteriorly. So this tumor overall was very big, and cutting into it, you didn't even need anything. It was like cutting like butter. And so anytime you feel that happening, that's bad, because what is anterior to the part of the larynx here, right? It should be your thyroid cartilage. And so that should be kind of tough to cut through. And so if it's cutting like butter, that is a bad sign. So upon serial sectioning, you can see that it extends pretty much everywhere. So this was a very extensive tumor. And the reason I put this in is because I want to show you how these spaces come into play. So this is just all of the slices kind of sectioned for you. And now I'm going to show you some individual slices and show you the anatomy. So on here, I labeled them 1 through 4 and then 5 through 8 here. So we're cutting kind of, think of it as like a circle around the larynx, right? And so the first one I want to show you is slice 2. So this is just slice 2, a separate picture of that kind of blown up. And on here, you can see that this would be the epiglottis up here. But importantly, this is all the way at the lateral side of the epiglottis. So this is like the lateral border of that epiglottis. That is not a cut. That is the border of the epiglottis. So on either side of that, then you're going to start that paraglottic space, right? So if we were a little bit more medial, like maybe even on the other side of this, if we flipped the section over, that would be the pre-epiglottic space. But because we're now lateral to that epiglottis, this down here is going to be that paraglottic space. And remember, that's continuous with that pre-epiglottic space. So here you can actually see the tumor extending into that paraglottic space. And the other hint that you know that this is paraglottic and not pre-epiglottic is because you can see those chords. So on here I've labeled the true and false chords, as well as that, oops, I put vestibule, it should be ventricle here. And you can see that it's at that level. So you know that this whole area is going to be that paraglottic space. And so you can see that tumor is extending directly through there, which is where I put all of these red stars. And importantly, it also extends all the way to that soft tissue margin. So the soft tissue margin is inked black here, and you can see that that tumor is abutting it at least, maybe even extending through it. So that would be a section that would be perfect for a perpendicular soft tissue margin, right? And then you would also want to document it here inside that paraglottic space. And through here, you're going to also see it, like, do you see any normal thyroid cartilage here? Not really, right? And so it will also have extended all the way through the thyroid cartilage, which you'll see once we get to staging, that the thyroid cartilage is very important. You want to talk about outer cortex versus inner cortex of the thyroid, but in this case, this has invaded through both the inner and the outer cortex. So this is going to be a T4. So for this, let me write it for you so you have it. But if the tumor is extending into the paraglottic space, that's going to make it a PT3. But in this case, it's extending also through the inner and the outer cortex of the thyroid cartilage, and it looks like it's invading through part of the strap muscles, right? So this looks like muscle, and you can see tumors in that. So through the strap muscles and through the thyroid cartilage, that's going to make it a PT4A. So you would want to document all of that. Now, here's another section, and this one I wanted to show you the pre-epiglottic space. So notice the difference here. This is not the border of the epiglottis. This is a physical cut through the epiglottis, because you can see that cartilage, right? And so this space anterior to that epiglottis, that is your pre-epiglottic space. And you can see tumor extending into that too. So this is this slice here, slice 4. And you can see tumor all in the epiglottis. So you would want to take a section there documenting the tumor extension into there. And you can again see it inside that soft tissue and abutting the inked surgical margin. Here's another one showing you that pre-epiglottic space. So this would be the epiglottis, oops, cut here. And then this would be anterior to that. And it's pretty much obliterated all of the normal fat there. And you can also see it extending through the thyroid cartilage here. So this is slice 5 blown up here. Now, as we're moving more laterally to slices 6, 7, 8, these are now going to be that paraglottic space again, right? And so that would be this here. This is slices 6 and 7. And now this would be tumor in that paraglottic space. So again, you would want to document that. And you would definitely want to document that this is bilateral as well, because you always want to say whether it's confined to either the right or the left, or if it's crossing in both sides. The other thing you want to mention for any larynx case is where exactly that tumor is. And so we already went over the 3 areas of the larynx and the structures involved. So I made a note of them here for you. They're color coded, of the different structures in each area. But we also have this fourth designation for tumor location. So you have the three areas of the larynx, but then you also have transglottic. So you can call something a transglottic tumor. And what that means is it's crossing that ventricle in a vertical direction. So whether it's going, either inferiorly or superiorly, it's crossing that ventricle. And so that would be a transglottic tumor. So now moving on to the staging. So here's an example of a supraglottic cancer. So I just showed you the supraglottic area, and remember that's going to go down to about the level of the ventricle. And so here you can see that this tumor appears confined to the supraglottic area. So you would call this a supraglottic tumor, right? So the staging for each area is going to be a little bit different. They're all fairly similar, but they do have separate designations on the AJCC classification. So supraglottic cancers in general, these are going to remain localized usually. And importantly, these are the tumor behavior is influenced by exophytic or ulcerative growth. So something that you want to mention in your report is whether it is ulcerative or exophytic, and that can be helpful for the pathologist when they're going into the report to fill out the CAP checklist. So exophytic tumors are going to tend to remain above the ventricle, and they're going to typically, not always, but typically have less mucosal spread. Whereas ulcerative tumors are going to tend to stay more inferior to the ventricle and the thyroid cartilage. So if the pathologist can put that in the report, that can help determine tumor behavior. And it can also help you when you're trying to figure out where to section, because as we know, a lot of these head and neck cancers are not that visible grossly, but then sometimes you'll see it histologically. So if you know that it's exophytic, you may want to take some additional sections above the ventricle, whereas if it is more ulcerative, maybe you want to take some extra sections inferior to the ventricle. So here is the staging, and I'm not going to read this to you because that's a waste of everybody's time, but I did go ahead and highlight the different anatomic structures that we went over so that hopefully now you can go back to those anatomy pictures and kind of review these, because if it's in the staging, it is up to us to put that in our report and take those sections, because if we don't mention it and we don't section it, then the pathologist can't fill out their entire staging, and then a lot of the information can't be obtained if you go back to the specimen, especially with larynx, because once you dissect these, they are in pieces, right? I mean, I'm sure you all know this. You've probably all grossed larynx specimens. Now here's another example. So this one is going to be a glottic tumor, and glottic tumor, these are not that commonly just found in the glottis. So this one, it kind of looks like it's extending into the subglottis, but this was the best picture I had for this. So a glottic tumor is typically going to stay in the glottic area, and these are classically going to invade into the thyroid cartilage. So the extralaryngeal spread of these typically, if it's located in the anterior midline area, it will go through the thyroid cartilage and the cricothyroid membrane, whereas if it's located a little bit more laterally, or if it's just kind of spreading in both directions, it can go through that cricothyroid space. And in that picture I just showed you, here's a picture of that same tumor cut open. And so this is the specimen bisected, and you're looking at it from a medial view, and you can actually see right here that that tumor really didn't look, too horrible from the mucosal view, but you can actually see it extending into the thyroid cartilage here. So this would be like normal thyroid cartilage, and then here you can see that it's kind of obliterated by tumor, right? And so that is showing you a perfect example of how those glottic tumors can go just straight through that thyroid cartilage anteriorly. So here's the same thing. Here's the staging, and I went through and I highlighted the different anatomic structures we reviewed. And it's showing you that if it's invading into that thyroid cartilage, it depends how far it's invading through. So if it's only going through, let's change colors. If it's only going through the inner cortex of that thyroid cartilage, it's going to be a T3. But if it goes farther through the outer cortex of the thyroid cartilage, then it's going to be a T4A. And so it's important to get a full section of that thyroid cartilage so that under the microscope, you can tell how far that tumor has actually gone through it. So if you can, try to get that full section of that thyroid cartilage. And then lastly, we have the subglottic cancer. So this is that same picture because, again, like I said, this one's kind of also extending into the subglottis. So typically for subglottic cancer, they're going to spread in a circumferential manner and involve the glottis as well, typically. But more commonly, you'll have that glottic tumor, like we just talked about previously, that will extend into the subglottis. And it looks like that's what's happening here. So if it extends into the subglottis, that's when you're typically going to be more likely to have cartilage invasion and extralaryngeal spread. And so typically a subglottic tumor is going to have, in general, a worse prognosis than the other subtypes. So here again is the staging, and I did the same thing. I went through and highlighted the different parts that we reviewed. And so notice here that, again, if it's going into that thyroid cartilage, that is going to be either a T3 or a T4. And so that full section of that thyroid cartilage is going to be very important. Also those paraglottic spaces and the preepiglottic spaces, right? So here's that same case that we had earlier, and we were going to call this a transglottic tumor, right? Because it's crossing, it's in the supraglottic area, it's definitely in the glottic area, and it's probably extending a little bit into that infraglottic or subglottic area as well. So this would be an example of a transglottic cancer. And as I told you, this is a T4. So typically these transglottic cancers are going to be ventricular lesions that are going to spread either up or down to involve the supra or infraglottic areas. So typically these are going to invade that paraglottic space, the lateral part of the thyroid and the cricothyroid membrane, and they're going to have that extralaryngeal invasion. So these typically are going to be pretty aggressive. That makes sense. They're transglottic, right? But something that's interesting about these is they often have very little mucosal involvement, and that's exactly what we saw in this case. So when we first opened the specimen, it's like, oh, this doesn't look too bad. But then once you cut deeper, it is way more extensive than it originally looked like. And so that is a fairly common presentation of transglottic tumors. And that's basically what I just said. It's just in note form, so you can come back to it later. So those are the perfect, examples of these different classifications, but oftentimes it won't be that textbook example. So here's a couple other specimens that I've had that don't really neatly fit into any category. And so you'll really have to use your judgment, and that's why reviewing this anatomy is so important, because you can mention which structures are involved. So you can say, it's half a centimeter away from the area epiglottic fold, or it doesn't involve the epiglottis, and it does involve the ventricle and the false cord and the true cord. But if you don't remember that anatomy, then it's tough to give specifics, and that's going to make it tough for the pathologist to classify this as a certain type of tumor, right, for staging purposes and for prognosis. So here, you can call them, you can maybe call them transglottic, or you can call them glottic, and then as long as you're mentioning the specific structures that it involves, then that can help with the classification later on, because oftentimes what you'll see with these is they do extend farther histologically than you can see with the naked eye. Here's another example. So this is, obviously a supraglottic tumor because it's pretty much obliterated that epiglottis, but it's also gone through the glottic area as well. So this one, it's kind of tough to call this just supraglottic versus glottic or transglottic. And so again, taking those sections and documenting exactly what anatomic structures they go through is going to be very helpful. Now, if you remember the lymphatic drainage of the larynx, you should hopefully remember that the lymph nodes are going to be in levels 2 through 4 that drain the larynx area. So typically, if you're going to get a neck dissection associated with a laryngeal carcinoma case, it will be a selective dissection of levels 2, 3, and 4. So here's an example. This was the first slide too, of a laryngeal specimen that actually had the neck dissection attached. And so sometimes you'll get them like this, and other times you will get them separate. And so typically this is like the standard care nowadays is levels 2, 3, 4. But there have been some recent studies looking into level 4 dissection because there is significant morbidity associated with level 4 dissection, such as phrenic nerve damage, and the phrenic nerve, remember, innervates the diaphragm, so that would be pretty severe damage, right? So high morbidity and mortality with level 4. And so the recent studies, I don't know if there's enough to, change the course of treatment yet, but there are studies looking into it that are saying that the rate of spread to level 4 is very low, and so maybe perhaps we should start doing only levels 2 and 3. But for our purposes, we're going to just talk about levels 2, 3, and 4 because that is still technically the standard of care at most institutions. And so here, this picture is reviewing those lymph nodes for you. So you can see that the larynx area is draining into those jugular groups. And remember, these are in level 2, these are in level 3, and these are in level 4. You also have some thyrohyoid lymph nodes and the Delphian lymph nodes that can be resected as well. So neck dissection review, remember that you have a couple different types of neck dissection. So the classic radical neck dissection that is essentially the definition of a neck dissection is going to be pretty invasive. So it's going to include the sternocleidomastoid muscle. So remember, we just reviewed that at the beginning. The internal jugular vein, the spinal accessory nerve, remember that's going to travel, it's going to innervate the sternocleidomastoid in the trap, and it's going to travel across that posterior triangle. And then it's also going to include lymph nodes from levels 1 to 5. So technically in the neck, there are 7 levels, but for our purposes, we're just reviewing neck dissection. So we're going to just talk about levels 1 through 5. So that is a radical neck dissection, but then sometimes you will get things that are modified. And so a modified neck dissection is still going to include the level 1 through 5 lymph nodes, but sometimes one or more of those other structures, so either the sternocleidomastoid, the accessory nerve, the jugular vein, those won't be included in the dissection. So it's still all the lymph nodes. That's the main takeaway, but not necessarily the vein and the muscle and the nerve. And then if you want to do something a little bit more selective, you can just take out certain levels. So typically, like we said, for the laryngeal cancer, you would take out levels 2 through 4. So that would be a selective neck dissection because you're not taking out all 5 levels. But sometimes you'll just get like a level 1 dissection, sometimes you'll just get a level 5, etc. So it just depends on the pathology present and what the lymph nodes are that drain wherever the tumor is. So the levels are based on anatomic designations. So level 1 is going to be actually split into 2 sublevels. So it's split into the submental group and the submandibular group. So this is why we reviewed that neck anatomy. So remember the anterior and posterior bellies of that digastric? Well, those I've highlighted here for you in the purple color. So this would be the anterior belly, this would be the posterior belly. Now the anterior belly on the right and the left sides is going to be the lateral boundaries of that level 1A, and the hyoid bone is going to be the inferior. So it's essentially forming this little triangle at the chin area. So remember your anatomical terminology. Mental is referring to the chin area, so submental literally is just below the chin, and that's exactly what this is. So metastasis, typically in this area, these lymph nodes are going to occur from mouth, anterior tongue, the anterior mandible alveolar ridge, and the lower lip. And that's why you don't typically get these with a laryngeal carcinoma specimen. Now, the level 1B, or the submandibular group, so still level 1, this is now made up of the anterior and posterior bellies of the digastric muscle. So here you can see it would be this triangle here, and then the mandible would be the other border. So importantly in this area, I would go ahead and just highlight this. That has your submandibular gland in it. And so if you get a full neck dissection, or at least a neck dissection that has level 1 in it, that can be invaluable for orienting your specimen. So find your submandibular gland, and that can really help you. It should be the most anterior and superior portion of a neck dissection, right? So metastasis in this area, it's very similar to level 1A, except you also have the nasal cavity and some of the submandibular area and a little bit of the face. So here's the lymph nodes in those areas. So I put level 1 kind of all together here, but you can see that these lymph nodes in general are pretty superficial. Now levels 2 through 4, so again, we mentioned that these are the ones that travel right along that internal jugular vein. So these are also called the superior, middle, and inferior jugular nodes, or you can call them the deep cervical lymph nodes. And these are divided into thirds, so superior, middle, and inferior, and those are going to be levels 2, 3, and 4, respectively. So here, level 2, this is going to be from basically the top or the bottom of the skull down to about the level of the hyoid. So these levels are based on where the bifurcation of the carotid is, which is great for surgeons because they can see the carotid, but we're not typically going to receive a carotid artery with a neck dissection. And so it can be kind of arbitrary for our purposes for dividing them. So when I'm looking at it, on a body or a diagram, I like to use the hyoid bone because a lot of diagrams won't show the carotid. But again, you're not typically going to have that unless it's attached to like a larynx specimen. And so oftentimes when we're orienting these neck dissections, the split between levels 2, 3, and 4 can actually be kind of arbitrary, which is why it's so important to have a good line of communication with your surgeons. So levels 2A and 2B are split by where that spinal accessory nerve travels. So that's what I drew in here with this dotted line. So remember, the spinal accessory nerve is going to come out that jugular foramen and then travel across that posterior triangle like we talked about earlier. So that's what separates that kind of rectangular area, which is all level 2, into these two little like triangular areas here. Now, metastasis to this area, this is going to be from the oral cavity, the nasal cavity, all 3 levels of the pharynx, and also the larynx, which we know, right? So here you can actually see those lymph nodes. So what I highlighted there, that muscle, that's the stylohyoid, so that would be kind of the superior border of this. And you can see that the lymph nodes are in that upper jugular group right there. So here at the level of that hyoid is where I drew that yellow dotted line, and that would be that inferior boundary. Now level 3 is going to go from that carotid bifurcation or that hyoid down to where that omohyoid muscle is going to cross. So remember, we said the omohyoid has 2 bellies, the superior belly here and then the inferior belly here. So right where that inferior belly is crossing, that's going to be that inferior border of that area. And then it's going to go from that sternohyoid muscle to the edge of that sternocleidomastoid. So again, in this area, we know it's going to have larynx, but it also can have spread from the oral cavity, the nasal cavity, and then all 3 levels of that pharynx. I don't know if I said that already. So here, that's where these lymph nodes are. So again, here I've highlighted that omohyoid, and you can see that these would be that middle jugular group right there, right along that internal jugular vein. Now level 4 is just basically going to be the rest of the area of the sternocleidomastoid down to the clavicle. So it starts where that omohyoid had crossed through, goes down to down to the level of that clavicle, and then metastasis from this area, it's also still going to have larynx, which we know, but importantly, this is also going to have thyroid and cervical esophagus mets, and it's still going to have some mets from the hypopharynx, but it's not the full pharynx. So levels 2 and 3 had all 3 areas of the pharynx, whereas level 4 typically is only going to have metastasis from the hypopharynx. So that's something of note. Now, level 5 is essentially the whole posterior triangle of the neck, and then it can be divided into 2 sublevels. So this is going to be the lymph nodes that travel along that spinal accessory nerve, and that's why we took the time to review that anatomy, because if we know that that spinal accessory nerve is traveling like this, kind of across like that, then it's going to be those lymph nodes that are kind of along there, right? So metastasis in the 2 level 5 areas are going to be from the nasopharynx and the oropharynx. So those would be up here in the level 5A area, as well as some of the posterior scalp and the neck. So here you can see that these would be the nodes included in there. So you have the lymph nodes right along that spinal accessory nerve here. And then also, just to kind of take note of, the supraclavicular nodes are also included in this group, in the level 5 group. So I know that's kind of a lot, and you don't, I guess, technically need to know all the different boundaries of these. I just thought that maybe we needed a nice review of it while we were doing the larynx anyway. But for our purposes here, here's all of them put together. And I think this can be very helpful. And keep in mind that you do still have those levels 6 and 7. It's just not classified in a neck dissection. So how do you orient a neck dissection? So I know that we all learned in school probably how to orient these, in the classic instruction is that it's a Z-shaped structure and you can just orient it like a Z. So you want to look for that submandibular gland, and that's going to be the most anterior and superior part of the specimen, right? So you can find that. Usually it's pretty easy to find. And then you're going to have this Z shape coming down, and you can use that sternocleidomastoid muscle as that kind of middle part of the Z, and that would be levels 2, 3, 4, right? And then if you're trying to orient right versus left, you can use the internal jugular vein, because that's going to be on the internal or the medial surface of that sternocleidomastoid. So theoretically on the body it would look something like this. Now the hard part about this is it typically, technically the level 5 consists of all of this, and so if you get a full level 5 dissection, it's not going to be a Z shape because it would include all of this. So I highlighted just the part in the yellow just for illustration purposes to kind of make it that Z shape, but keep in mind it may not always be that perfect Z. So once you have it oriented in your levels, you can then go ahead and cut off level 1 and level 5, and then you would only have levels 2, 3, 4 left, which you can essentially just divide into thirds to determine those different levels. So theoretically, if you're looking at this, you're like, okay, find the Z and then cut off 1 and 5 and then divide 2, 3, 4 into thirds. Easy enough. But the problem is, as with everything in pathology, it's not going to be normal. It is not going to have a perfect anatomical appearance. That's why it's being removed from the patient, right? And so here are some examples of neck dissections. Now, do any of these really look like that perfect Z? No, right? And so these are real life examples of specimens that you're going to get, and that's why it's so important to understand that underlying anatomy to be able to orient these. So you need to be able to understand the fiber direction of the sternocleidomastoid, understand where that internal jugular vein is, find that submandibular gland. But most importantly, you need to have that line of communication with your surgery team, because these should be oriented by the surgeon. So these actually, all 5 of these were oriented by surgeons. And big thanks to our colleague Samantha Saunders, who actually gave me these pictures, and she went out of her way on her last day of her work week and stayed late to get these to me. So big thanks to you, Sammy. Thanks for these. But at her institution, you can see that they do get oriented. And so all I did was just kind of crop out that orientation to demonstrate that they are really difficult to orient sometimes. So here, once they have it laid out and the surgeon says, okay, this is level 2, this is level 3, you can then dissect it based on that. Same thing, I did this for all of these so you can see here that they're nicely oriented. And so with these, you definitely want to just communicate, and you want to use that anatomical knowledge as best you can. And then in summary, I just put all the different levels here and the areas that they tend to have metastasis from, if they have metastasis at all. And for our purposes for this review, remember that levels 2, 3, and 4 are most pertinent for the laryngeal carcinoma spread. So thank you for listening. I hope that that was helpful. And the references I used for this were my pictures, Sammy's pictures, and then also the AAPA grossing guidelines. If you haven't looked at those, they're fantastic. Highly recommend. And also the CAP checklist for laryngeal carcinoma specimens. So hopefully that was a good review. Thank you for listening.